We're going to have two individuals join us on the second panel, and we're going to focus more on patient access and patient's perspective on medical cannabis. So joining Dr. DeAngelis and myself on the next panel is Christina Montoya, who has lived experience with rheumatoid arthritis, chronic pain, and multiple gut disorders. And she will highlight some of the challenges she faced when seeking medical cannabis treatment. With her experience, she has been actively involved with advocacy groups, including the Arthritis Society of Canada. Finally, but not least, we have Dr. Blake Pearson, a practicing physician and recognized leader in cannabinoid-based medicines. Dr. Pearson has treated patients with a multitude of complex conditions, but namely autism spectrum disorder and managing behaviors associated with dementia while reducing polypharmacology. He is also a physician that advocates for patients and making sure that those medical documents have that extra level of coverage so that patients can have specialized treatment programs. Thank you for joining us today. Well, thank you all for joining us on this panel as well, and I think we have a lot to unpack, especially around the recent legislative review process that happened. What they identified, Health Canada identified, was some of the logistical issues for patients, including cost of coverage, reasonable access to cannabis, and lack of education. So I'm going to start with you, Carlo. If you could cover where you came from the beginning to now and how that patient education has been structured to help those patients.
Yeah, so again, we started, as I said, we really wanted to make sure that patients were using cannabis safely, and so part of that is education. And so we've developed our own materials, which need to be updated, by the way, but that was really just trying to give the patient an honest sort of understanding of the potential benefits of cannabis, potential side effects, why it's important to discuss the issue of cannabis with their healthcare provider, and then the process in terms of what's involved in sort of having cannabis authorized. And so those are sort of the structure of our education and our counseling of patients when they're picking up their cannabis. That involves, of course, the dose titration, and we go through the legislation in terms of travel issues, driving. Again, trying to educate the patient as much as possible so that they're using the product in the safest way possible. So yeah, that's the way we structured it.
That's great. And Christina, I know you mentioned in our discussion last week that was one of the challenges. When you got that medical document, there was no education to be provided, and you were really left going out there to get some products. Can you speak to your journey in getting medical cannabis, and what were the points that did help you along the way that you wish you could see out there for patients?
Well, I only wish that I had Dr. Carlos' model of care when I first accessed medical cannabis. Initially, I attended this clinic. I'm not sure if I can say the name. No? Okay. What I did like about it is because there was a physical clinic, but I could see a doctor, a physician talking to me and going through the challenges of how to use cannabis. I was really scared because I was Colombian and really I was raised in the time where Pablo Escobar was there. So to imagine, for me to accept cannabis, my own stigma was very strong. So even navigating that own stigma was difficult. But through this clinic, I was able to accept that, yeah, we can use medical cannabis for chronic pain, but the appointment was 3 hours long. And for a patient with chronic pain, that is just not acceptable. But things changed after, I would say, the pandemic. Most of these clinics went online, but then also faced another challenge. The logistics through, I wasn't seeing a physician. It was over the phone. They will say, you need to sign up online. This is your medical document, and you will access these products. But as a patient, I want to navigate the portal. I saw hundreds of products. I said, why am I just going to use the one the doctor said? That one seems it's more affordable, seems to be, I made my own assessment, which I don't think that was right. But I was just left there navigating that. I didn't know if the product, what they were offering was actually the content of the CBD oil was really offering that amount. So I started really doubting the medical system, the medical cannabis system at that point.
Oh, and that's a great point you made, is that a lot of patients do go onto these portals and they are shocked and they don't know where to go. And it speaks to the need for healthcare provider oversight in prescribing these products. Dr. Blake Pearson, you've worked with specific populations, including dementia and children with autism, which is a very unique population. Can you speak to some of the challenges you see with those type of patients?
Sure. It's interesting because there's parallels between the kiddos with autism and the dementia folks in long-term care, and we're primarily using cannabinoids to manage the behaviors. So in long-term care, calling out, agitation, sometimes they're physically responsive, and same with the kiddos. Sometimes they can self-harm, they can be agitated, they can harm their parents, but we're really using cannabinoids to manage those behaviors. And what's interesting is there's a big push in Canada and Australia to move away from antipsychotics, neuroleptic drugs to manage the behaviors, because they come with a whole host of side effects, a black box warning for death being probably the worst, but weight gain, obesity, diabetes, a number of side effects. And so here we are, we have cannabinoids which actually in practice are quite effective in managing these behaviors. And just like Carlo does, we're using specific doses of THC and CBD, specific products, and maybe that's kind of a theme for today, real medicine. And when we're talking about coverage, I think the insurance companies want to see that, pharmaceutical companies want to see that, actual structured data with regulated products. But anyways, it's interesting because they actually are effective, better tolerated than the antipsychotics, a big push to move away, but cost. So there's no coverage for those indications in private or public payer systems. So we have a new therapeutic with efficacy, emerging evidence, but cost is often the barrier. And while it's a negative, I think in dementia in particular, it highlights that may be an avenue, as we all talk about regulated products, preclinical research, to real-world trials, to potentially coverage. Dementia, to me, or the responsive behaviors, is an area to look at because you actually have that pathway, and there's a big need for it.
And Dr. Pearson, when shoppers, medical cannabis by shoppers, pre-COVID had put together a plan to go to long-term care homes and work with caregivers to hopefully help and implement cannabinoid-based medicines into their care. However, that largely went, COVID being a factor at that time, but also because of the barriers to medical cannabis, really got left and there had no success. So what have you done differently to make sure that these patients do have access to care, and how do you work with these long-term care homes to get cannabinoid-based medicines to them?
So a labor of love to start, because it was quite a lift to, as you know, Carlo, to educate the physicians and the directors of care at the homes, the staff, to get over the stigma initially. But once that was done and the relationships were built, we did have success there, but it took that. We did have some funding, and this highlighted the need for coverage, more funding. We did have a 3-year grant where we did a study looking at cannabinoids, dementia on mood, responsive behaviors, and what we found was there was efficacy, and then the reduction of polypharmacy was very obvious. We were able to wean neuroleptics, we were able to wean trazodone or benzos for sleep. So it was a little bit of a mix of labor of love to start, but then getting some federal funding. So I believe now the wheels are in motion again for that indication to really expand upon and develop products for that space, and would love to see, again, more coverage.
We definitely agree with that. And Christina, one thing you've mentioned is cost. and that being such a great barrier to being able to access cannabinoid-based medicines. And I know that you spend a lot of time doing patient advocacy and also learning about the space. Can you share on your perspective what the biggest opportunities for physicians and groups like us would be to help support patients better?
Well, just like you said, access. As an example, I participated in Dr. Clark's study, and it was very interesting to really go use the same products for about 6 months. But I admit, after 6 months, I could not afford to continue with the cannabinoid-based therapies. And so to me, the challenge is like, how can we support patients for that continuity of care? If it's working, because it was working for me to manage my chronic pain and mostly my fibromyalgia, it was wonderful. Like I'm not using opioids, and I haven't used it for like 5 years since I started using cannabis. And so for me, it's part of my toolkit for chronic pain. I'm not going to say I'm going to replace my medications for my rheumatoid arthritis or anything like that, but I feel that there is a huge opportunity for physicians to really assess what the patients and accept. And I even challenge you as a physician to go to a recreational store, because that's where the patients are getting this, and the message that you're getting. Go as a patient and say, hi, I need something for my pain. See what you can find out there.
That's literally the talk, my kind of a recent talk I'm giving to physicians and nurse practitioners, and the title is, Stop Sending Your Patients to Bud Tenders. Seriously. That's the title of the talk. Yeah, because it's so important. It's tongue-in-cheek, of course, but that's really an important message, that we have these resources. The bud tenders, if you will, aren't equipped to have these medical discussions, but we really need to put the emphasis on the docs and the NPs and the pharmacists to have these conversations.
Yeah, that's a very critical point, and we discuss it every day. We have a lot of patients that, when they can't afford, they do go to recreational channels. They're recommended products that I don't even know what it is half the time, and that's scary. And eventually we do see them come back to our platform when they notice there is care, but we do provide significant discounts and need to provide discounts for patients to be able to afford. But of course, that's also a sustainability issue for the industry, given that there's large excise taxes applied to some of these products. On that perspective, Health Canada did mention that they want to remove excise taxes from medical cannabis. Do you guys believe that would help, or is that still too minimal of an effort to make sure that patients have medical cannabis access?
It's the start, so we'll take any progress, right? But the truth is, for my patients that are on disability or ODSP here in Ontario, who, let's say they have chronic pain and they've been referred by their GP, they want to wean their opioids or their mean morphine equivalents. They're certainly open to CBD or THC. Some even start, see success, and it's the saddest thing when they're doing better. We've weaned down their morphine equivalents, or they've come off their opioids altogether, and then they have to go back because inevitably, even if the excise tax was removed, the cost is too much for someone on disability, which their wage hasn't gone up with inflation, so they're struggling to buy groceries and things like that, so they can't pay for their medication. So to me, that's the glaring example where there needs to be coverage, and it's almost a human rights issue at this point.
That's a great point, and something that you mentioned to me last week that really stuck out was how challenging, even in the situation where there is coverage available for those patients, it is to get all those documents through, and then once they have the documents through is also product selection. And if you can speak to some of those challenges you face and maybe some of the improvements that could lie in helping patients access that coverage that they do have.
It's, again, labor of love, because obviously physicians in their busy practices don't have a lot of time to go over the options and the access pathways and filling out insurance forms and little shade to, let's say, WSIB. I don't know if we have them in the house, but making a physician fill out forms upon forms back and forth, and I do it because it's my passion, but there's a lot of barriers to even the coverage that exists. So aside from even what you were mentioning about picking the right product, just getting it over the line to actually have that option and get it approved takes a lot of legwork. I don't know if you guys have similar experience with that.
Yeah, we've had similar experiences, and we do have some patients, despite us recommending, they can't afford it and they don't purchase, right? I mean, I think that's, Karolina, I'm thinking about what I answered your question earlier, and this sort of ties into this as well. One of the things we also do in educating the patients at the time of counseling the patient about the use of their product is we actually go through why we've chosen this product, the research behind it. There's actually stability data on the bottle. You actually know when the product expires, which is not a requirement from the cannabis guidelines. So when you go to a licensed supplier, there's no expiry date on those products. And I tell them what's on the label is actually in the bottle. It's actually been measured. When you go to, again, a licensed store, you'll notice that there's a range of THC or CBD in that product, from 0 to 50 milligrams of CBD. Wow, right? So we educate patients about that. And some of them, again, realizing that we're not just talking about a product that you're picking off the shelf at a cannabis store. Some of them will say, okay, well, I'll try to make this work somehow. But again, it's difficult because they can't afford it. It can be expensive. And we've tried to reduce our prices as best as possible.
And Dr. DeAngelis, in your time too, you've done a lot of healthcare provider education, especially at Sunnybrook Hospital. And as you mentioned earlier, there was a lot of stigma, and patients were just not going to their healthcare providers. But what type of education have you provided, or frameworks that you have set to help physicians feel comfortable in prescribing medical cannabis? Because I do think that makes your program very unique, and that's why you're seeing so much adoption.
Yeah, I think it goes back to what I mentioned in terms of, and I wish I had a slide about our authorization form. We're very specific on the form. It's not just 3 grams of cannabis per day. We select the product. We tell them how much THC and CBD is in it. We say this is the starting dose. This is how much THC and CBD the patient's going to get, and we even have refills. So it's like total authorized based on the dried equivalents of that product. So it's virtually a prescription that says the patient can get up to 45 bottles, 2 bottles every 2 weeks, and it's all based on the the cannabis equivalents to the dry product, right? And so I think the fact that we're using, again, a very standardized form, it gives them all the information that they need to sort of understand exactly what I'm signing off on. I think that's gone a long way, and I think just over time they've realized that we're very diligent in terms of what we do. And to talk about hate mail, so just to tell you the story, so when we decided that we would be actually, once the regulations changed that would allow us to provide cannabis to our patients directly, and we brought it in-house, I sent an email out to all the staff and said, we can do this now. And there was more hate than support. But there was one individual who was absolutely very supportive of us, and that individual basically said, they do a great job. They assess the patient closely. They follow the patient closely. They're not just sort of giving out the cannabis and not following up with patients. I'm fully supportive of what you're doing. And that was only one individual, but I think that was really important to us to sort of, all the naysayers, to say, hey, they're very conscientious in terms of what they're doing. So I think that helped as well.
I think that's the model. That's the key. Traveling around Ontario, teaching physicians, specifically at family health teams, we did something similar where the average physician isn't going to uptake cannabis. It's too big of a lift. But if you provide some type of framework, and we would designate champions at the family health team, like a motivated NP pharmacist or doc, but that kind of team approach or multidisciplinary approach seems to work well with respect to this, and I think that's something to build on in the community, and here too with your program, I think it could be expanded upon.
I think the other thing is they're always authorizing the same product, right? We've got just those products.
Yes.
They've become familiar with them, right? So I think that was a decision we made right up front, very early on, that we would go with one set of products and use them on a regular basis,
And is there
so that
any-
people would become familiar with them.
Sorry. Is there anyone from insurance, like private insurance, in the crowd? Or
I think a lot of them are online today.
okay, okay. Well then, can't do the show of hands, but I really think that's what they're going to need to see is examples like that, small product lists with some evidence, preclinical evidence, real-world evidence for specific indications, and then hopefully we can get more coverage.
May I say something related to that? I know that private insurance can really contribute to this, but we're also missing the employers. Many times the employers have the authority to really authorize what goes into the private insurance. And if there is stigma, which I experienced, that is easier for a person who take a smoke break every hour, but God forbid, you mentioned that you use medical cannabis for your chronic pain. So I think that's probably another area that I have experienced that I'm afraid of saying, I'd rather say I'm taking opioids than taking medical cannabis. And I actually will appreciate that they will cover my medical cannabis rather than opioids, because I don't like the side effects, personally, as a patient. And so I think that's another layer of challenges there.
Yeah, that's a good
You
point.
make a great point that we haven't touched on today, so thank you for bringing that forward. And the one thing I wanted to ask you, Christina, was hearing Carlo De Angelis speak about his patient approach, and that most patients do want to speak to their physician or oncologist and make sure that they know about their medical cannabis use. In your experience, you've gone to these clinics, you've gotten your medical document. Does your primary physician know this, or do you still feel that stigma associated with medical cannabis?
That's evolved positively. When I first joined in 2017 and I brought up to my rheumatologist, it was like, what are you doing? And I was afraid of talking to him. Then after a while, I even attended the Rheumatologists Association conference, and where they're starting to be more open because more patients with arthritis are searching for cannabis. So I haven't faced that challenge, or I guess that barrier in that area. Rheumatologists are being more open to understand that patients are using cannabis. But what I see is that they don't really understand what are the drug interactions. At some point, I was told, well, if you are on methotrexate, I think we'll appreciate if you take a monitoring more your liver enzymes, that sort of thing. So I appreciated when I actually saw a rheumatologist who specialized in cannabinoid-based therapies. So that was amazing. Like, she was amazing. Dr. Caroline Landed. But I think that was so amazing to actually, she could kind of fuse both worlds. And I felt the support from her. It was great. And because I saw the rheumatologist write in the document, then the other rheumatologists kind of followed suit and never questioned it.
And that speaks to that healthcare provider education. She was exposed to it, and also exposed to being comfortable with cannabinoid-based medicines. And I'm really excited to see where we can go with this, where if now Health Canada invests in making some changes to help patients feel more comfortable with access to cannabis, but also physicians getting that education. And the most recent recommendation asked whether, or recommended that we have this pool of educational resources that physicians can access. Is that enough?
No. Because you have to make them want to learn about it or uptake those educational resources. And so I don't know what the answer is there, but there has to be some type of skin in the game, or some type of value add, really. That's what I've seen to be most effective, is here's the education, but here's why you need to learn this. Like, this is actually of course it's gonna help your patients, which is the name of the game, but there also has to be, believe it or not, some type of incentive to the physician, like, hey, this could really this could really reduce your mean morphine equivalents. We're all under, those requirements to reduce those. Or that patient of yours who may be a frequent flyer, meaning they're in the office all the time, this could be one of the medications where you ease their symptoms, and maybe you don't have to see them as frequently, but some type of value add for the doc in addition to the education.
I feel that the approach of following up with the patient, I think even there are patients who can afford it and want to use it. But when they go to a cannabis clinic and they left with, this is the document, I follow up with you in 3 months, they are afraid of going through the titration process. So the fact that with Dr. D'Angelo, they are following up 2 to 3 times a week, that's amazing. And I probably will be more compliant to like taking the cannabis and see results within like at least 3 months. Because I always say like I just give it 3 months. It's like when you start a medication for rheumatoid arthritis, they tell us give it up to 3 to 6 months to take effect. So we cannot really expect, in my experience, I cannot expect cannabis to have that rapid effect unless I vape it. But you don't agree with that.
I think that's part of, I can't tell you how many times we get patients said, I tried this and it didn't work. And then when you actually get a bit of a history in terms of, well, they took 2 doses or 3 doses, they didn't titrate. So you didn't really give it a fair trial, right? So I think that's really another thing that maybe hasn't been talked about today is the importance of titration, not from the perspective of trying to prevent side effects, but actually trying to see whether the cannabis is actually going to work, right? And educating the patient that first dose isn't necessarily going to work, but that's what they're used to, right? They're given a medication for cholesterol, high blood pressure, for controlling blood sugar, and it's like, well, this is the dose, and this is what I take, and it's helping me. So, that expectation is there that, well, I take this, and it's going to help me, but it's not. You need to find the dose. It's no different than using opioids for pain management. You start at a dose and you titrate to the benefit or side effect profile, right? So I think we have to think about cannabis in that way as well. It's not just one dose, but we have to educate patients about that as well, that it's not just one dose. Every patient, and we say that in our counseling, every patient is different. We don't know what your dose is going to be. So I think that's a really important comment that you made in terms of, again, trying it to maximize the potential benefit.
Well, it looks like we're running out of time. Do we have one question, or does anybody want to throw out a question? All right.
I'll just shout.
If you want, it's right behind you.
Oh, is it?
Yes.
Carlo, thank you very much for that. I think Avicanna team and your team should be applauded again for the work that you've been doing. That's fantastic. So the question I had is the model that you've implemented obviously has potential implications for other disease areas. I'm thinking stuff like dementia. I know that's one area Blake's very interested in, even in rheumatoid arthritis, Christina, as you mentioned. Any guidance or advice that you would give to healthcare professionals who want to try to set up a similar sort of system for other disease areas? What should we be looking for? What should we be considering? Thanks.
Yeah, thank you for that question. I would say that you need to find a champion, somebody who's willing to, learn about cannabis, to basically set up the program for you and help you sort of help patients navigate through the whole process. And I did it because I was interested in cannabis, and we had these nightmarish situations that happened to some of our patients, and it was like, okay, well, maybe we can do something about this. And I guess I'm passionate about it, and I really believe there's a role to play, and that we need to be more patient focused in what we do. But you need that champion. You need that. When I went to my boss and said, "Here's what I want to do," it was like, "Oh, okay." And I just basically said, "We're not going to make money on this. This isn't about making money, right?" Which is sort of interesting, because the administration up above her, when she went to them, said, "Oh, we're going to make all this money." I said, "No. This isn't about making money. This is about using cannabis, appropriately, right? And it's going to take a number of people. I have a student that's with me. 12 months of the year, there's a student that's with me. Actually, that's why I'm going back this afternoon. Brand new student, so she needs some help. But so I'm hoping that even having those students, I have 12 of them throughout the year, they're learning through our process, and hopefully they go out there into the community in terms of pharmacy and sort of feel comfortable in terms of maybe helping patients through this process as well. But I would say, yeah, you need to find a champion. Yeah.
So essentially, you're saying we need to clone you.
Yeah.
It is an opportunity too, though, even on the revenue side. Like, I think companies or health networks that really dive into this, meaning something like what you have, Carlo, the family health teams, these specialty clinics, for instance, but with backing from someone like UHN, with industry funding, with possibly insurance funding, but getting all the players and people in this room together, I think there's something there that could generate revenue, progress research, and move medicine forward, and why not do it all?
Yeah, that's a great point, and hopefully when you start generating revenue, it helps to fund more students that you can then train, and more Dr. Carlo D'Angelis is out there. So thank you all for this panel, and thank you for joining us today. And right now we're going to shift to lunch, so I hope everyone's hungry. I know I'm starving. Enjoy your lunch, and we'll be back at 1:15.